The first one wasn't.
All right, everybody can begin the meeting.
Good morning, everyone. It is 8:02 a.m. on January 28th, 2025. We will call the regular meeting of the Board of Health to order. Let's see, so attendance, we have board members Frank Ehrlich, Anthony Santella, and Joan McNeil. We have staff members Aniela Pignon, Brian Weeks, Teresa Argandesi, Darlene Hoffler, and Megan Fogno. Megan, did you just say there were two different Zoom links sent? So we might have to make sure we have everybody who needs to be here.
Yeah, I'm sorry to barge into the meeting. Yeah, there was two sent at the same time. It looks like they're coming from, I don't know. Anyways, there was
all
like
right.
two reminder emails sent.
Okay. Thanks, Megan. I'll try to see if there's anybody else who needs to join us. So we'll call the meeting to order at 8:03 a.m. Sorry, I already did the roll call. Is there anyone from the public who wishes to speak? It's public comment right now. Please raise your hand.
No hands are raised.
Okay. All right. The next item on the agenda is the acceptance of minutes. So do I have a motion to accept the December 17th, 2024 meeting minutes?
Yes.
Do I have a second? Anthony seconds. Thank you. Any discussion on the minutes? All right, hearing none. All those in favor of accepting the minutes, say aye.
Aye.
Any opposed? Any abstentions? All right, minutes passed. Thank you, everybody. Next, we're going to move on to our epidemiology updates. Good morning, Brian.
Hey, good morning, Deanna. Good morning, board. Good morning, everybody. So yeah, we're just going to do a quick kind of roll through respiratory viruses and, some of the other kind of caveats related to it, as well as just kind of a quick exploration thing. So let me just switch over to sharing my screen and we'll go dive right into things. All right, so you should see my screen share right now. That's the CDC Respiratory Illnesses Data Channel. This is, again, the community snapshot right now showing it for the country, for the United States. And so this is data that's up to date as of Friday last week. So it's good that this data is, available and updated as well. So with that said, the overall respiratory illness activity in the United States is high, as we kind of expect. We're still in the peak of the season here in January 2025. Then looking at it and zooming into emergency department visits, we see that COVID is low and decreasing, flu is very high and increasing, RSV is at moderate and decreasing. The wastewater viral activity in the United States, COVID is at moderate along with RSV, and then flu is at high. So if we zoom in now to Connecticut, because that's definitely geographically more relevant, you can see again, high respiratory illness activity for Connecticut. Emergency department visits, COVID is low but increasing, flu is high and increasing, RSV is at moderate and decreasing with the current data that we have. But then also zooming into wastewater viral activity, it's an important indicator too. It's a predictor too in terms of where things are going. You can see how COVID and RSV remain high and then flu at very high. So again, just being mindful of that. The fact is, again, we're still in January, so we're getting through the season. And so then if we jump forward a little bit, we can then look at the emergency department visits. Again, this is looking at it from the nation. So this is just kind of zooming in on the data and just seeing the trends there. You can see again how flu in the blue is very high in comparison to COVID-19 and RSV. So that's just giving you a little bit of perspective. And then again, if we zoom into Connecticut, same story, but a very steep curve, as you can see, in terms of flu in comparison. But you can see how COVID's kind of popping up a little bit there. RSV seems to be dipping off. So it's just something we want to be mindful of because, as you may recall, COVID sometimes comes in here and there. We were dealing with a summer and fall wave before, kind of got, outshined, so to speak, compared to flu. But just keep in mind that especially as we approach February and the latter parts of February, then March and spring break, COVID may really rear its head. So it's something else just to anticipate for the future. But right now, obviously, the beast that we're dealing with right now for emergency department visits is flu. But I just wanted to mention that specific to Connecticut. And then just one other thing, just to keep in mind that, with these respiratory viruses, they could also be the cause, but also there's other things circulating in terms of developing, bronchitis and pneumonia. And so one of the things that has been actually experiencing a peak of activity, especially recently, even like the summertime last year, but it's still continuing, is Mycoplasma pneumonia, which is caused walking pneumonia, which is, again, it's a common infection, but it is in the mix here with everything else that's going on. So it's something we just want to remind people too, that they should follow up with their healthcare provider if they suspect that they're developing it. But again, who's being impacted relative to the data from the national trends from the CDC? You can see here it's more or less pediatric, so 18 years of age or younger, in terms of experiencing those higher trends, leading to ED visits. So just wanted to kind of emphasize that the highest right now is the 5 to 17-year-old age group, but then again, it's followed by the 1 year or less age group, as well as the 2 to 4-year-old age group. So just want to emphasize that we have other things going on, and then that's also further emphasized with the NREVSS dashboards. That's the National Respiratory and Enteric Virus Surveillance System from the CDC, and you can see here how it's emphasizing that influenza is the highest, but it's also then followed by rhinovirus and enteroviruses, along with just a whole other mix in terms of RSV and everything else that we kind of anticipate. So there's a lot happening, right? Again, 'tis the season. The colder weather definitely contributes to it, and just the closer exposure that occurs because of that colder weather. And then emphasizing the point about norovirus still remains high, nationally speaking, as well as even regionally speaking here in the Northeast. And so you might have heard the term coined in the media, quademic. So QUAD, quademic. And so again, that's just emphasizing the point that, COVID, flu, RSV remain high, generally speaking, as well as norovirus. And so we're kind of getting hit in all these different ways. And so again, that just re-emphasizes kind of, just the prevention measures. Along with that, you may also heard in the news, there's the CDC Health Alert Network message. Again, this is tailored for healthcare providers, but accelerated subtyping influenza A in hospitalized patients. Again, this is just an emphasis to detect H5N1, which is something that is emerging, that is being monitored very closely. Again, predominantly now just in backyard flocks, birds, as well as dairy cows. But, there have been very sparse, very, very sparse human cases. And so it's something that we want to mitigate in terms of developing, an opportunity for it to really transmit community-wide in humans. And so it's something that's just very important to detect early. So it's just another thing in the mix here too, that as we get through the season, we want to manage and be mindful of too. And so this all kind of cycles back to, just this general infographic. So actually this one's in Spanish. More or less, we're going to be communicating to multiple audiences today in terms of this, which is great. I guess I opened up the wrong infographic, so I'll just run with this one because again, it's the immunizations, right? There's also the hand hygiene and respiratory etiquette. There's also the air quality, so that's the air filtration, opening up your windows when you can, when the weather is nicer out. Then along with getting treatment, and then also staying home and preventing, transmission amongst others if you suspect, as well as you're confirmed of knowing that you have the illness. And again, you don't kind of come out of, staying home until your symptoms have improved and you no longer have fever without any fever reducing medications for at least, the 24 hours. But then for the remaining 5 days, you take additional prevention measures, which includes the masking, that's the social distancing, and also testing yourself, with the rapid tests if you have them available, making sure that you obviously stocked up on them. Just to know if you are still shedding the virus. Because if the rapid test is triggering a positive, even a weak positive, is indicative that you are still shedding enough of the virus that you could also transmit it to others. And so just being mindful of that, again, you guys heard this message a million times. So that's why it's also beneficial that we have this written out in Spanish as well for our different audiences. Just as a reminder, because this helps mitigate relative to all the things that we've seen here, whether it's bacterial, but also this is especially for viruses. To mitigate transmission in the community and get us through the season in as mild a manner as we can. And so again, we're doing well in comparison to what we could have, compared to say 2 years ago. So, we just got to keep getting through it because again, we have that second wave that typically happens with spring break. And so we want to mediate that as much as we can too. So that's again, the overall overview. the respiratory illnesses, including the viruses that we, the big three, the quademic component with the norovirus, but then also being mindful of the development of secondary infections or other developments that come with, whether it's from the respiratory viruses or just other things that are circulating too bacterially. And so that's like the pneumonia, and just be mindful of that and following up with your healthcare provider if you start detecting or suspecting that you are developing these things. So that is my overview for today. Thanks, everybody.
Thank you so much, Brian, for a great update as always. Do any board members have any questions?
Yeah, Brian, about 3 weeks ago, there was an article in the global health section of the Sunday Times about a virus that's become very common in China called HMPV, which is the metapneumovirus, human metapneumovirus. Is there anything going on with this virus in the states, and more importantly, in our state?
Yes, so human metapneumovirus also presents during the respiratory virus season. It's not as common as the others, the big three that we were just discussing. But it happens, and it's typically presents in immunocompromised or immunosuppressed individuals. Typically, you see it more in the hospital settings. And so there are sparse number of cases that do occur, especially during the season, sometimes year-round. That's human metapneumovirus, parainfluenza. There's other viruses that are circulating. That's the point I try to emphasize when I showed you the NEVRSS data. There's just so many other bacteria and viruses that contribute to respiratory illness that circulate that tend to also rear their heads during the season, but they are not as large in terms of volume. That got a lot of attention just because, one, it's China, and we kind of know what came from China in terms of SARS-CoV-2, which leads to COVID-19. And so, yeah, there's going to be clusters of activity, especially, again, those susceptible to the illness that would contribute to them manifesting and maybe having to go to the hospital. But regardless, this is something that circulates globally, and especially during the season. So it's not something we have to be particularly concerned about. But again, going back to those prevention measures, that will help mitigate risk for anybody. So that's just really kind of the core message here and the core reminder, too, in terms of ensuring that it doesn't gain that additional traction with everything else that's kind of going on.
Thank you.
Thanks, Brian, and thank you, Frank, for the question. I just want to note that Ken Lalim, our board member, joined at 8:14 a.m. Are there any other questions or
I was going to
comments?
ask something similar about bird flu, because I know I've been reading, maybe not Norwalk, but in, as close as New Haven or Upper Fairfield County, there have been some cases. So I assume nothing in Norwalk.
So there have been evidence of backyard flocks, that, as you mentioned, in other parts of the state. So what we're really focusing on now is, and Brian, you can, or Teresa or Darlene and others can jump in, really just about the messaging to others that might come in contact with, wild birds or with wild animals out, just reminding them messages. And so the state has been pushing out some messages that, like, to us, through DPH, and that we've shared with others. So we're sort of in the monitoring phase right now, and we're also. This is another point that I was going to bring up during my director report, but I'll just jump in now. We're thinking about, all the different health issues globally, locally that could be happening, and how do we prepare ourselves for the next thing that we would maybe be confronted with. So we're taking a look at our emergency preparedness structure and the ICS structure, incident command structure, thinking about, how we responded to COVID, how did we staff up, how did we resource, how did we situate ourselves, and taking a look at all our plans and thinking about, how we would go about, handling the next situation. So we're sort of doing things on the back end, thinking through the planning phase of it, and then just monitoring, locally. And Brian, I don't know if you have anything you want to add to that.
No, I think you kind of hit the point home. I mean, again, if anybody suspects that they came across any sort of dead animal or especially dead birds, not to really engage it. That would be to really call the appropriate authorities, whether it's animal control, and have them kind of manage it or refer you to the appropriate authorities to remove it. I think that's just the most important thing, because we want to reduce any sort of human exposure. But yes, nationwide, there are, the birds are starting to, fly around, interact in different ways. Northeast is not an exception there too, and so that's going to contribute to further spread. And so again, what the biggest thing we want to mediate is, not ensuring it doesn't enter anybody's backyard flocks or any other animals that they're raising, but then also increasing that risk for human exposure. So one should not interact or engage any animal that looks sick or seems ill, let alone is dead, and then call the appropriate authorities relative to it. That I think that's the most important thing too, to mitigate the illness. And so also, I don't think I could put a link in the chat, but there's also something from the state health department in terms of just other guidance that we can kind of reference to.
Thanks, Brian. Thanks, Anthony, for the question. Any other questions? All right. Next on the agenda is reaccreditation updates. So I'm going to pass it on to Daniela.
Thanks, Deanna. Good morning, everybody. I'm just going to be providing a little update on our work to get ready for reaccreditation. We are set to begin submitting stuff for our application for reaccreditation in April of 2027. So it seems like a long time away, but we really have got a lot of work to do from now until then. So I'm just going to dive right in, and then we can have questions at the end. So just a quick overview, we are going to review the purpose of reaccreditation and accreditation in general. We're going to take a look at our master planning and tracking tool, look at packets for our leads in the reaccreditation process, take a look at the timelines, and then I'll talk a little bit about implementation. So reaccreditation by the Public Health Accreditation Board, also known as FAB, is really important because it demonstrates that we are performing in a way that is consistent with nationally recognized practice-focused and evidence-based sets of standards. It's a completely voluntary and optional process and program. If you are interested in doing it, what local health departments do is they collect documentation, and then every 5 years in between that, they continue to submit documentation to demonstrate that continued conformity. So as you all probably know, Norwalk was an early adopter of accreditation and was first accredited in 2014. We were actually the first local health department in Connecticut, so we still like to tout that. And in March 2022, we were reaccredited with a 100% score. We've been submitting annual reports every year since then on an annual basis each March. We're actually working on our reaccreditation annual report right now. And so the actual reaccreditation process is much larger than the annual report, which is kind of like a little mini process where we kind of just check in on a couple of things. But the actual reaccreditation process requires us to submit at least 93 pieces of documentation that demonstrate our conformity and commitment to standards and performance improvement. So within those 93 requirements, a multitude of those actually require, 2 examples to be demonstrated, or there are a number of elements within those requirements. So this is a really heavy lift. And we are working with really a ton of people from across the health department to make this happen. So what we did starting last summer was to take a look at all of the measures in their entirety and to see how much work there actually was to do. So there are 10 domains, and within each of those domains, as I mentioned, there are 93 requirements. So Deanna, Megan, and Catalina and I took a stab at kind of delegating some of these. And what we were able to see is that we put together planning tools and documentation processes, systems and tools that really kind of explained to each lead what the requirements were that they were going to be responding to. We also provided guidance packets to each of those leads, and we reviewed the documentation system, and we reviewed different types of forms for submission for everybody. But really before we kind of got to that part, we made sure that we were splitting up all of the work appropriately. So we took a look at these 93 different requirements. And as I mentioned, myself, Deanna, Megan, and Catalina, who is our public health program associate, and Megan, who was our former FAB accreditation coordinator, and tried to make those all kind of even across the different domains. We did a second review and we just redistributed the requirements to make the lead assignments more balanced, because there are a number of assignments that, we thought, oh, that would be great for Deanna, but at the end, Deanna had like 20 different requirements to respond to. So we wanted to make sure it was a little bit more fair and that everyone would have enough time and capacity to respond to everything. So after that second review, we developed those packets that I talked about. And so those guidance packets actually had information about each piece of documentation for which a lead is responsible to respond to. As the work progresses, leads are able to redelegate their requirements as needed. So for example, say Deanna and I are working on something together and Deanna realizes, oh, well, Aniela, you've actually worked on this. And because I have 20 measures and you have 10, why don't we give this one to you? And so, we are able to kind of work through that as time goes on and make sure that everything is fair and that everyone is able to respond in the most appropriate capacity. Excuse me. As I mentioned, we created guidance packets for each of the documentation leads. So knowing that there were a ton of people who were going to have a ton of different things to respond to, it felt like a big heavy lift to ask everyone to go in and kind of put together their own planning tools. So what we did was actually create these charts for everybody to use, where they'd be able to go in and see the measure, the overhanging measure that kind of leads to the requirement. They are able to see their requirement number, the guidance, which is just a sort of a basic, the basic information for that piece of documentation. Tells you what kind of document type you're going to be creating. So whether that's a narrative, an example where you're actually pulling documentation and highlighting things, or if you're pulling a policy or procedure and you need to kind of demonstrate within that policy or procedure that we've met certain elements, that's what that section tells you. There's also a data within column. So FAB, is a 5-year process, but some of the documentation that they ask for needs to be within a 3-year period, a 2-year period, or a 1-year period of that submission or application date, so that they can see, that we are doing things in a timely and appropriately timed manner. We also indicated support staff, so people that we thought would be good to support the lead in typing up or creating that documentation. We also provided some notes, some basic suggestions on things that we thought might be helpful for those leads to think about as they were considering their potential options for documentation. After meeting with leads, we actually added additional 2 columns, one of which was the projected due dates. So you'll see a lot of these say like spring 2025, April 2025, things like that. Most of the documentation that we are trying to pull together, we are trying to pull together within this year, knowing that next year was going to be a heavy year for reviewing and some of the other measures that require a shorter timeline. So those 2 or 3-year ones. And then the last column is tentative plans for documentation. So as we are meeting with leads, or as I'm meeting with leads, I am talking to leads about, what are the ideas that they might brainstorm and come up with to meet these different elements of documentation that we need to provide. And so what we end up doing is just kind of plugging in some of those basic ideas. Usually there's a primary one. Sometimes there's a secondary option. If there's 2 examples, we'll usually come up with 2 activities or examples at the very minimum. Sometimes we do 3, so there's an extra one to consider. And then within these guidance packets, not only is there this table at the beginning, but every single requirement that they need to respond to has been put into this packet. So anything that is not relevant for a lead would be, blacked out so that they wouldn't need to read that. It's all redacted. But everything that is relevant to their particular documentation is in that packet. So they're always able to refer to that for their own edification. The documentation system that we put together is pretty simple. It's just a file saving system where leads are responsible for producing the required documentation, and I, as the accreditation coordinator, am a support for verifying that the proposal meets FAB requirements. Anything that we do actually put together, we have an official landing space for on our server. Those are the things that are ready for submission. And so we try to save everything under the appropriate folder and make sure that everything is completely organized. My job is to make sure that all of it is completely organized. So if anything gets saved in the wrong place, I'll be the one kind of moving things around. And then we have a OneDrive accreditation folder, which is a mirrored system for all of our working materials. So what that allows people to do and our staff members is really to get into OneDrive and work on active documents. So for example, Megan and Darlene would be able to go into the same document and collaborate at the same time. We'd be able to see track versions and changes, anything that we wanted to see for the history of the document. Then we can ask those people, you know, oh, like, how come that was written this way? Or, you know, why was this change made at this time? Really gives us that opportunity to make sure that we're clarifying everything. Myself as the accreditation coordinator and or the director of health, Deanna, will review and provide feedback on drafts of documentation until the narratives, examples, every piece of documentation is finalized. It's a very iterative process, making sure that everything is perfect, that our I's are dotted, our T's are crossed, everything is perfect. At the very end of this process, I, as the accreditation coordinator, am responsible for uploading the documentation to FAB, and Deanna, as the director of health, is responsible for the submission to FAB. Again, that's going to be happening between April of 2027 and September 2027. So we sort of have July as our date for submission to just kind of make ourselves, you know, on time. As you guys can see over here on the side, it's just a little visual of how I've asked everybody to get to their different requirements. And so, as I mentioned, there is a mirror system on OneDrive, and everybody can navigate this pretty easily. So how is this happening in practice? You know, once we actually had a sort of a big overview with everybody in August of 2024, where we talked to all the leads. Since then, I have been meeting with documentation leads on an agreed upon basis, and that depends on the lead, their comfort with the FAB process, their familiarity with it, and the amount of measures and requirements that they need to respond to. Because as I mentioned, you know, we did try to make this as balanced as possible, but there are some staff members who, just based on their role and their experience, do have more requirements to respond to. So during these regular meetings, again, they're usually monthly or quarterly, we do some brainstorming. Usually that's coming up with the ideas of what we want to include in our different documentation examples. Sometimes it'll be brainstorming on a particular element of things. We coordinate group discussions. So anytime a particular piece of documentation maybe requires a little bit more insight, or you know, talking to some of the other supervisors or other health department staff members to get their insights and perspective, we try to do that as much as we can. We plot our requirement responses. So what that means is every time that we finally come up with an idea and we say, all right, this is you know, what we want to do, we put it into the tracking document, and we also use a timeline to monitor our progress. We develop soft timelines, not hard timelines, knowing that all of these are draft due dates, and a lot of this is subject to capacity, you know, things that come up as needed. And we also have as needed updates to the tracking tool and timeline. So, you know, during these regular meetings, I am always updating all the tools, but I am also making sure that if somebody emails me and says, oh, here's just a little FYI, I'm putting that into the tracking document and the timelines to make sure that everything is the same across all of our documentation and all of our systems. In summer 2025, we're going to be having, excuse me, our next all leads update. So we'll be bringing back together all of the leads and reviewing the documentation status tracking tool. So for each documentation lead, I have put together a timeline, and so you can kind of get a sense. This is an example of Bill Mooney's timeline, and so we plotted, you know, when we expected documentation to be completed by within 2025. We have not yet gotten to the part where we're talking about prepping documentation for submission, because, as I mentioned, that's largely going to be in 2026. But creating these timelines has provided us with the ability to get a sense of what our cadence is going to be, make sure that staff members are not trying to overload themselves at any particular time of year, that they can consider their own personal schedules as they're creating all of this. And then, of course, we have a master timeline that speaks to all of the measures and the requirements and when we are planning to respond to all of them. So As you can see, it sort of mirrors the same format as the other individual timelines where we've got the light shading, the dark shading. And so instead of it just being the measures for a particular person or the requirements for a particular person, it's all of them and they are listed by domain. And as you can see on the right side, it's quite a number of them. And so it's a big timeline to kind of look at. Implementation has been going really well. So far, we've already started to have documentation roll in from individuals who have put together, either narratives that they've written up in the past couple of months, or they've gone through different documents that we have at the health department, such as plans, processes, and have started to highlight some of the things that we would like to look at. So far, our progress is pretty good. I'm really proud of our team. I think they've done a great job. That master tracking tool that I just want to kind of go back to really quickly has been very helpful for everybody to, again, go and take a look at what everybody else is working on. So say we want to talk about lead and our lead program and how we've responded to that. Well, we don't want to talk about it for every single requirement. So it's a good way for other leads to be able to take a look at what everyone else is doing and to make our documentation requirement submission as diverse as possible. So as I mentioned, I am very, very happy with all the progress that we've been making, but we are more than happy to be taking any questions and really excited to kind of share with you all the progress that we make in the future. And that's it. Thank you. Any questions? Okay, thank you.
Thank you so much, Daniela. A lot of really great work, a lot of coordinating, there's a lot to accreditation for anyone who's been through it or worked on it. And so it's a lot to oversee and manage and to assist and help everybody. The whole staff pulls together, does the work, but thank you to Daniela for coordinating it all and Megan for helping her too. It's nice that we still have our former accreditation coordinators on staff to help, but Daniela, you're doing a fantastic job leading us, so thank you. All right, next item on the agenda is culturally and linguistically appropriate services policy. So those who've been on the board for a while may know that this is a policy, used to be the cultural competency policy, that it was passed over 10 years ago when we first started going through accreditation, but that there's been a movement sort of shifting more towards cultural humility, not acknowledging that, learning about other cultures, you're never going to be 100% knowledgeable about every different culture. We have to avoid, stereotyping about different people, but then also the humility part thinks about like looking at yourself and your own beliefs and how that shapes your view of the world. So we're sort of, wanting to embrace that shift too within our department and to shift the policy that way. And so Darlene, Teresa, and Yella, they've done a lot of work related to this policy, added a lot of new terminology. We've started to update some of the appendices and updating lists, those who are, we have a few staff members that are actually trained in medical interpretation. As we know, that's different than standard interpretation, because in medical, there's all these complexities related to that. So we have 3 staff members trained in that to help support the clinics. What else? What am I missing? Teresa, Darlene, if you have anything, sorry, Anielle, if you have anything to add to this, but really just trying to modify, update the policy to reflect, more current terminology and where we are as a department. And we're, it's still in the works, but we wanted to bring it to the board to show you the work and to see if you have any questions, discussions related to the policy.
I have none.
No.
How
Thanks,
are
Richard.
people trained on the class standards?
So Darlene, do you want to jump into some of that?
Sure, we've brought in other organizations to provide us some training. It's AHEC, I believe it is, came in to provide staff training. So we continue to do that on a regular basis.
Thank you.
Oh, the thing I was thinking about, I wanted to mention was Janet had some feedback around literacy and looking at ways to incorporate that within this policy too. So we're going to take a look at this, and I know that's already incorporated in some of the other policies, you know, like external communications and others. So we'll take a look at that and weave that feedback in. If I think everyone can agree. I know that's something that's, you know, been an initiative of the board in the past, enhancing health literacy.
I had another question too. How are the languages revisited? The language, the trend, you know, I'm trying to see, I have it open, but I don't know what page, in the written communication. I'm just curious, like if there were Chinese or Korean or other kind of Asian languages that are commonly translated.
I can
So
speak. I'm
oh,
sorry.
go, no, go,
No, I
Darlene.
was gonna say, you know, as we encounter the different groups, we will certainly get those materials translated in the appropriate languages. So we do respond to the changing and shifts in the population.
And Darlene, you want to talk a little bit about language line too, how you utilize that too for
Yes.
in-person interpretation too?
We do have the language line phone interpretation service available to us, so that as folks come in who are in need of language other than the more popular ones, such as Haitian Creole and Spanish, then we are able to utilize that service to provide us assistance. They also have a translation service as needed. So we can send documents there as well for a fee.
Darlene, you might have said it before, but what grade level is the material in?
That was one of the items that Janet had mentioned. We currently have it at a 5th grade level. I know Teresa could probably speak better to this because that's her domain, but she had suggested 3rd grade level. Teresa, I'll leave it to you to speak
Okay.
more.
Oh,
No,
third
that's
grade? Okay.
actually, yeah. So our external communications plan includes a checklist to look at things like health literacy, the use of jargon, and how to check the reading level on our written materials and our mass media communications. And it is really a challenge to get it below 5th grade level when you're talking about medical information, because some of the medical terminology there's not, you know, there's no equivalent.
Yeah,
And
that's true.
so we're
Mhm.
constantly reviewing those materials to try to, you know, bring them as simple as possible, because and then also several of our staff receive crisis communications training, which is
Okay.
a little bit different, but also emphasizes the fact that if people are normally reading or comprehending at a 5th grade reading level, when they're under stress, it's a lot lower. So, you know, trying to find ways to talk about complex information in a simpler way, it's something we're always striving to do.
Okay. All right. Sounds good. Okay. All right. Thank you.
Frank, did you have a question or?
Yeah, and this question, I hope does not breed any political discussion. The question is meant purely from a staff standpoint. As regards the gender question, for example, how are we or how are you handling that we've been told to use only 2 genders? Is that what the Norwalk Board of Health is doing? Department of Health is doing, or are we doing whatever we feel is appropriate, which may be 2 genders? There are significant changes being made and coming about in terms of some of this information. And I guess my question is, are we paying attention to it or ignoring it?
I'll just say we haven't changed any of our internal policies. We're still operating as we have been.
Good. Thank you.
Mhm. All right, any other questions? All right. So I don't, do you want us to work on incorporating like some of, showing the clear linkages with the health literacy in this policy and then bring it back next month? Or do you want to, I don't know if you want us to consider adopting these revisions? We've done that in the past where the board wants us to adopt the changes and then we, do the general, like you give the general feedback and it's passed, or you want us to bring it back next month to take a look for a formal vote,
No. I don't think so. I don't know what the other members.
No, I'm okay with it. Yeah.
Yeah, I think it's fine. I think I forgot to say this before, but I'm sure you've done that. I'm sure you have this or you've done this already, but I know there's a reference at the end to the HHS website, the Think Cultural. Like just given the state of affairs that we're in, you may want to make sure everything is like downloaded, printed. That website may go away, just like others have. So if you have a reference to like I said, a federal government website that unfortunately, if it has the word culture in it, may, because that's where it lives, right? It's an HHS policy. But I think it's okay to vote on it.
Thank you, Anthony, and thank you for that suggestion. We will take that
just
in.
want to
We
mention
will
very
do that.
quickly-
Thank you.
I just want to mention very quickly that we do have those materials downloaded, but for this particular policy, but we'll take that into consideration for all the other policies as well.
All right, so can I ask for a motion to approve the culturally and linguistically appropriate services policy as revised?
So moved.
Frank, do I have a second?
I'll second it.
Okay. All right, I'll give this one to Joan. All right, thank you. Thanks, Anthony will be the third. Do I have any further discussion? All right, all those in favor say aye.
Aye.
Any opposed? Abstentions? All right, motion passes. Thank you very much, board, for your support. And thank you to the staff for all their work on the policy. Next, we have budget updates. We had a really great, I want to let everyone know we had a really great opportunity this past month to go before the Community Services Committee of the Common Council to present on our budget requests. And so Lamont Daniels, our Chief of Community Services, worked with the Common Council members and Chairperson Nicole Ayers on putting that presentation together. And so it was a great look at, the Community Services Department as a whole. As you know, it's Human Services, Health Department, and the library. And so we were able to give a presentation on what we had put in for the budget request. And I know I've already given you all those highlights, but I really emphasized the need for having the part-time environmental health person become a full-time staff member to support the additional work related to the increased mandates for lead inspections, as well as having the grant-funded public health nurse be moved to the city operating budget to keep up with all the clinical demands as well as the lead mandates. As you know, it's both environmental side of things as well as the case management and the clinical support as well. And so as I said, it was a great opportunity to really talk about the needs and just emphasize that, the request that we put in from the health department side, it's really related to both the mandates that are placed upon the health department, whether they be state or local, as well as the needs of the community, right? Advocating for what is needed for a healthy community. And also just recognizing the really difficult budget situation that we are in, and just trying to balance that all out. So it was a great discussion. One of the council members had a great question, if you're not able to get your funding request, what will the impact of that be? And so I was really able to emphasize that the lead work is mandatory. It's really critically important, both from a health perspective and a liability perspective. We have to do these inspections. They're mandates. And so thinking through, what else, how do we tackle all the work and how do we balance it all out? And, that, if we aren't able to fund these positions, that we're going to have to take a look at all the other mandates and thinking about, what are the absolute, the musts versus the, mays, all of that. And so I was able to articulate that. So that was, it was a great discussion. So, I'll keep you updated as it moves along, as I've said before, but that was a great opportunity, and we're anticipating, the recommended budget to come out next month. So stay tuned. It's just, there's multiple steps to this process. So we'll keep engaged, and I'll let you know if, if there's, further opportunities for the board to get involved and to express, your thoughts on the budget, further thoughts. Any questions around the budget? All right. And then next we have personnel updates. So wanted to share and let everybody know that our medical director is going to be retiring soon. And so that is a position that has been filled for almost, about 20 years. So it's a big position to fill. And so we'll be working, with the personnel department and others to fill that position, as well as all of you to provide your guidance and to help us with recruitment. And as you know, the board will vote on, confirming the medical director, because it's an integral, important part of our clinical services, and the board plays a big role there. So we'll keep you updated that we're going to be looking for a new medical director. David Reed has agreed to stay on until we're able to find a replacement. So we really appreciate him sticking with us. As you know, he holds the license for us in order to be able to operate clinical services. So we thank him, Dr. Reed, for all of your service to Norwalk and to the Board of Health for your many years, and for willing to stay on to help us. And we wish you well in your retirement, well earned and well deserved. At the same time as we're looking for a medical director, we thankfully have filled some other roles. We have a part-time advanced practice provider who's been supporting some of the lead work and other clinical services. She's been a great addition, Allison. And then we've also had Kaylee join us, who is our grant-funded public health nurse. So she's been wonderful to have as well, and she's supporting childhood immunization, lead, and other work as well. So those are just some of the updates related to personnel. Any discussion, questions related to that? All right, thank you. And then my last item was the director's report, but I sort of already talked about this. We've been working on just evaluating, I mentioned our incident command structure, and thinking about, what was written on paper and all those plans that we had over the years that really started with, thinking about, like, what if the city were faced with anthrax attack, after 9/11. And so how that's evolved over the years to include more planning for mass, for flu, for other things. And so how did we, operate, during the COVID pandemic, and what are our lessons learned there? And thinking about our new staff and our new structures, how do we situate ourselves so that we're prepared for the next health issue? And so our staff has been doing a lot of great work thinking through, what are the characteristics and qualities, the strengths that you want in the different positions, and where do our staff lie, and what are they really great at, what do they enjoy doing, and how do we, fit ourselves into a different structure and really make it more general to support any health issue, not just, dispensing medications due to anthrax exposure, really making it more general to all the health issues that we're faced with. So working through that now, it's a lot of great work. I'm learning a lot through it, so I'm excited. And once it's completed, or it's further progressed, we'll be sure to present that all to you. Any questions, anything else before we wrap up today? All right. Well, thank you as always to our board, to our staff for your amazing work, and we'll see you next month. Have a great
Yep.
day, everybody.
Take care.
Okay. Okay.